Vanessa, Lauren, hey, how are you guys doing today? I got interested in medicine after I got out of college. I was a pure chemistry major in college. I went to graduate school and I needed a job, so I went to a hospital and started working in a laboratory, and that's where I learned about medicine. And I became very interested in pathology, diseases. I learned how to be a lab tech, drew blood, and that's how my first interest came for medicine. I really had no desire or even thought of being a doctor when I was a kid or in college. In fact, I used to kind of shun those pre-med students because we were pure scientists. But then when real life kicked in, I got really interested in it when I started working at this laboratory in Urbana, Illinois. Generally working in that lab, and I had to teach myself how to be a lab tech, learn all the tests, got to know more what medicine was all about, and got to know the pathologist there, and he kind of inspired me to apply to medical school, really. During medical school, we didn't have it. I think we had one or two lectures in ophthalmology. That was it. I wanted to be an internist, and I thought, well, a good internist needs to know how to do a good eye exam. So I was in the military on a scholarship, and we had the opportunity to go to these different bases for training. So I chose a ophthalmology rotation in San Francisco at the Letterman Army Hospital, and that's where I became interested in ophthalmology. They had some very inspiring ophthalmologists there. I got real interested in taking care of the patients, and it was so nice to be able to see what was wrong with the patients. And I just, I was signed up to go to the San Francisco General Hospital for a rotation, and I said, I think I'll go to ophthalmology the second time, and I did, and I really got hooked. So I never looked back, and of course the chief there became the chief down here in San Antonio. I followed him to be his student, and he was my inspiration. Dr. John Schock was his name. I started this main office in 2005. This is our main, where we have the main testing facilities, the fluorescein angiography, the wide field, the high-tech visual imaging systems. But we have satellite offices for the patients in Kerrville, New Braunfels, Fredericksburg, Seguin, Stone Oak. We even go to the village, the Air Force Village place out in West San Antonio. So we go to a number of different places that make it much more convenient for the patient to come to see us. Now, we can do most of the treatments there, not all. We have to do surgery here at our specialized surgery center that has all the equipment for that. And if they require special, say if they're in a research protocol or something that may be eligible for, we have to do that down here. But 90% of the treatments we can do at our satellite office. Well, they are certainly rapidly changing. We've seen so many changes in the field of ophthalmology over the last 10 years. In order for me to keep up with those changes, it's very difficult. But it's made easier with modern technology and information technology. So, number one, we get things across my desk every day of magazines that are filled with all the latest journals and articles. I get emails from all the same places, headlines of what's new. And then I attend meetings and I talk to my colleagues. And I'm actually actively involved in research myself. So I'm sort of on the cutting edge because I get to go to the meetings where they tell us you can't tell anybody about this, it's highly secret because it's not known to the public yet. So I feel like I'm on the cutting edge of the research that's going on. So when I was in Vienna for a meeting last week, they had a session of live surgery transmitted from 4 different sites, from Belgium, from Ann Arbor, Michigan, and I can't remember where the 2 were, but it was live surgery that I could watch and learn without having to actually go to the OR of the doctor. So that's quite common anymore. Almost all of the meetings now will have live surgery that we can watch and learn from. There's a special meeting in Frankfurt that I like to go to that has doctors from all over the country and all over the world, really, that come there and do live surgery, and then there's an audience watching them. And the last time I went, there was 600 people from 66 countries. I can speak Spanish, habla español. I've studied Spanish since high school when I had to take Spanish 3 so my high school could have accreditation for Spanish or something for the school. There were 3 of us in the class, and I've been studying it ever since. So I can speak Spanish. I have Spanish tapes that I listen to in my car, and so I can certainly get by. As a retinal specialist, one of my big responsibilities is taking care of patients with diabetes. I've been doing it for years, and we've seen a gradual improvement in not only the patients taking care of themselves with new medications, but the treatment of diabetic retinopathy. Of course, diabetes can affect the retina in many ways. Mainly it causes bleeding and loss of vision from what we call macular edema or swelling in the retina. If we see the patients early, they come in on their annual examination, we can most of the time catch the disease early, treat it with either laser or some new treatments, which are pharmacology or basically eye medicines that we can use. And many patients can be treated successfully and maintain their vision. But it's very important that the patients come in on an annual basis and be treated and not wait until they all of a sudden get severe loss of vision, then come in. We can even help most of those, but it's much better to come in early and then we can start the treatment when it's needed. We're very conscious of the cost of the care of our patients. We know that that may be on their mind when they come in to see us because there's a lot of tests that may be necessary. We only do the tests that we feel are necessary for the patient and that are going to make a difference in their final treatment. And actually, the testing is not all that expensive. For example, the most common test we do is the OCT test. I think it costs about $50. It's not that much. But the most expensive portion are the pharmaceutical drugs that we use, and we have a choice. Some are more expensive than others. We usually start out with the ones that's less expensive. If it doesn't work, then we can go to the one that may be better. We also are very conscious of what the patient's insurance is. We always check that first, make sure what they're going to get is going to be covered by their insurance. And if not, then we work out a plan for the patients. And a lot of these pharmaceutical companies have plans of their own, will help pay the portion of the patient that the patient cannot pay. They might have a large copay or deductible. And these drug companies have foundations that will pay the copays for the patient based on their income, but they have very high levels, so it's easy to qualify. And so we have many patients on these plans that they don't have to pay anything for the drug. That these drugs can cost up to $2,000 per treatment, and if Medicare or their supplement pays most of it, if it doesn't, these foundations will pick up the copay. It's amazing. It puts the patient at ease because they can come in with that little credit card and they just, whatever is not paid, it gets paid by the credit card, by the company. That doesn't include all of the treatments and examinations, just the drug, but that's the large majority of the cost. Retinal surgery is something I've been doing for a long time, and the great thing about it is, of course, people come in and can't see or have loss of their peripheral vision, and I'm able to help them and get their vision back. It's a very frightening thing to have a retinal detachment or have bleeding in the eye, and it's very rewarding for me to be able to repair those eyes and be able to restore their vision. It's very visual, which I'm a visual person. I mean, I like working through the microscope. It gets magnified. I can see the retina, see the retinal holes, see the problem, see where to laser, fix it. And so that's one of the reasons I like doing retinal surgery. It's fun for me, and it's nice to see the patient the first post-operative day and they can see again, and it's very rewarding. Doesn't always work, but most of the time it does. I had an interesting case recently of a patient who had the vitreous gel pulling on the macula, and this was about to cause a macular hole. And I've been working on this new process of simply injecting a gas bubble in the office to fix that. So I injected a gas bubble in her eye, and the vitreous released, but she still had a macular hole. So I scheduled her for surgery. And the day before surgery, the patient called and said, "Dr. Mine, I think it's a little bit better." So I said, "Well, come on in, let's take a look." And then sure enough, it had gotten a little bit smaller. She said, well, give me another injection of the gas. So together we decided to do a second injection. So now I term this patient the double bubble. And sure enough, 4 days later, with strict face-down positioning, her macular hole closed without any surgery. So she was very excited. I have another one now that's called the triple bubble. It worked too. So this technique, I actually presented this technique of using this gas bubble to treat macular holes at the Vienna conference I was just last week, and it was very well accepted. There was another paper about a similar topic, and we had like a 78% success rate of relieving vitreous traction and curing macular holes with a gas injection in the office without having to have surgery. Well, I think my duty as a physician is to put the patient first, to do the best I can to cure them. I think it's my duty to use all the training, the knowledge that I've been given, the talents that I have, to try to make that patient better. And I have to know my limits. The majority of the time, in our office, we have the people here that can handle very tough cases that involve the retina.